Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Now, I want to jump right in without further ado. Director of the Department of Healthcare Services, Will Lightbourne, is with us this morning. He's we're very honored, sir, that you've made time to be with us and that you've carved out time on your calendar to be with our State of Reform community and audience. You've got a big task on your plate. You're doing a great job, and of course, you're not new to state service, and so we're all very interested in hear what you have to say. And I want to bring in, after your comments, Director, bring in Demetria Malloy, Senior Medical Director at Anthem, and we'll have a little bit of a conversation, the three of us. But before we get there, let me just turn over the keys to the car, sir, and let you take it away. We have you on mute still there, Director. One of the great scourges of our time is the mute.
The mute button.
Yeah.
Thank you, DJ, and thank you for inviting me to the conference this morning. It's a distinct honor. I'll be speaking in somewhat general terms, but this is the time of year when the governor's budget is still in development, and until it's released in January, we cannot say with certainty what will be in the health space. I know that Chair Ting and Dr. Arambula are speaking a little bit later, so they can talk about assembly priorities. And as you know, the final budget is always a process of consultation and negotiation. You also have a panel of DHCS leaders later today, and they'll be able to go into detail about initiatives already underway and can probably refine some of the things I want to touch on this morning. However, there's one overarching perspective I want to emphasize as being at the heart of and increasingly running through our thinking and planning for the years ahead. And that's the urgent need to address racial disparities and inequities in health outcomes, not just between races served in the Medi-Cal program, but also in relation to outcomes in other coverage groups. We don't have to look any further than the COVID-19 infection and mortality rates to see this. For adults in California, as of November, rates of death were 42 per 1,000 for Latinos, 48 per 1,000 for Blacks, 41 per 1,000 for Pacific Islanders, compared to 27 per 1,000 for both white and Asian populations. This is not just a factor of exposure, it's also a result of underlying health conditions and treatments. While Medi-Cal, which now provides coverage to more than 13 million residents and half of the children in California, is truly a godsend, the fact remains that significant disparities exist in this system. Some of it is a product of rates, less than Medicare and far less than private coverage, but some of it is also a result of systemic problems. We have access issues, both geographic. Different parts of the state have really very different supplies, and we have system fragmentation that even where the delivery systems exist, the connection between them is challenging for the most sophisticated of consumers. We additionally have a narrow clinical definition of healthcare. It's said that 20% of health outcomes are a result of clinical care. I think it's always wise to be dubious of any rounded figure like that, but whatever the actual percentage probably is, I don't think there's any doubt that a huge amount of what goes into people's wellness are conditions that are outside of the clinic and the doctor's office. We have a provider workforce that's unreflective of the community, and people of color self-report experiences of racial insensitivity or lack of cultural appropriateness. And candidly, there's a weakness on our part to hold our managed care delivery system fully accountable for addressing disparities. If we can address these systemic issues, we can realistically improve outcomes, not only for the victims of historical racial oppression, but for others whose vulnerability make them a particular priority for our care, people most marginalized in and by the economic system. As the Medicaid agency, we have two levers really to address these issues. The design of the program, what's in it, and the purchasing strategies that we use. And we intend to pursue significant change in both system design and in purchasing strategies in a mutually reinforcing way in the coming years. In the area of program design, at the beginning of 2020, the administration announced its intention to embark on CalAIM to commence this coming January as a replacement for the current 1115 waiver under which most of the program has operated since 2015. While the onset of the pandemic disrupted our schedule and our focus and our budgets and our delivery systems and our collective attention, the elements of this reform remain at the core of our goals here at DHCS. Those core goals, I'll try to highlight them in this fashion. The first is a deliberate and focused integration of physical, behavioral, and dental health care. And a focused integration in the sense that accessing one must make the rest available. For children, we also need to revise the medical necessity standards in the EPSDT benefit. Beyond the focused integration, we need to build on the success of the whole person care and the health home pilots and the recent very exciting work in ACEs Aware that we've been doing in partnership with the Surgeon General, expanding enhanced care management for high acuity, high risk target populations as a statewide service, not a county by county pilot, and including a suite of 14 in lieu of services as reimbursable Medi-Cal benefits to address social determinants of health. These in lieu of services would cover and include areas related to housing, related to nutrition, related to accessibility. They would essentially allow our provider networks and our plans to contract with the social care institutions that are capable of enhancing the health outcomes of the people that we serve in need. We also, as part of CalAIM, intend to enact payment reform to emphasize value-based payments in over volume and moving to regional rather than county-based rates so as to sort of improve continuity of care, accessibility, and network adequacy. Inclusion of home and community-based services in the Medi-Cal benefit. The goal here is to expand on a eventually statewide basis the availability of those sorts of services and supports that let people, whether through need by age or disability, to receive care as close to their homes as possible, rather than in institutions, and to more quickly transition people from acute care settings back to the home, or from skilled care, rehabilitation care back to the home. The timing of implementation of CalAIM is of necessity budget dependent. We have to be sensitive to what the long-term effects on the state budget have been of the pandemic. And so what I anticipate that we will be seeing is a sort of phased, staged implementation of the CalAIM goals. But as I said before, these remain our core commitments. In the area of purchasing services, we are, for the first time ever really, procuring at the same time all of the commercial managed care plans. So we call it a re-procurement, but they've never really been all procured at the same time before. This is a process that began in September with a request for information that was very widely distributed. We received literally thousands of input comments on it. This will next be followed by release of a draft request for proposals in the spring. And we anticipate releasing a final RFP in the fall, with the expectation that new procurements will go live in January of 2024. The RFP, I'm sure, will focus on a number of particular areas. It will embed the CalAIM services along with value-based purchasing, incentives for plans to employ enhanced care management, and the in lieu of services, the social determinants, and measured progress in closing disparities in health outcomes. A particular requirement will be commitment to local collaboration with public health, public and community social care agencies and services, services delivered to children in school settings. And this will have to be in part built on working with provider networks to ensure that the social, beyond simply the clinical skills, are embedded to serve our communities in ways that emphasize engagement and mutuality. The new contracts with the commercial plans will be mirrored in the contracts for the local initiatives. Along with this, our team will still be working through the COVID pandemic. Eventually, the wind down of the public health emergency programs, some of which have potential for significant disruption in terms of the eligibility functions, as well as some of the program waivers and simplifications that were obtained through CMS. We'll certainly be working with stakeholders to identify those innovations that came about during the pandemic that people are interested in seeing continued in various forms. Telehealth coming top of mind. These will, of course, have to be accomplished in close consultation with CMS, what will be a new federal administration, and in dialogue with our colleagues in the legislature. But it will be an eventful year, of that I am certain, and one in which we'll be building on all of the partnerships that State of Reform has helped to engender. So thank you so much, DJ. Let me stop there.
You know, sometimes people, when they're speaking, they have filler. There wasn't any filler in your comments there. There was a lot. You had a lot going on there, Director Lightbourne. Thanks for those. Let me ask you just this sort of fundamental question. How has this COVID experience changed the way DHCS is thinking about reprocurement? What will be different as a result of us having gone through this period of real instability and trauma for some people? What will be different in Medi-Cal as a result?
One of the things, well, there are a couple of areas that I think we would emphasize coming out of this. One is the need for close local collaboration. Without in any way finding fault with anyone, one of the things that I think people observed was that as different systems scrambled to respond, scrambled to engage communities, there was frankly a lack even of common knowledge of who each other was, who the players were. So between public health systems and the healthcare delivery systems that DHCS contracts with, there were gaps in information. When we had to ask our plans to work very, very quickly with the home and community-based waiver service systems, again, it was a little bit like making introductions to people who had never met. These sort of, those are the moments where we realize there's a great deal of cross-system engagement that everyone would benefit enormously from. A second area is that whole area of the home community-based service system. And so the priority to us of both embedding it in CalAIM and carrying that through to the reprocurement and the new contracts is central, because we have a large aging and disability population. And as we've seen from the pandemic, the institutional settings have been the most dangerous place for people. And so to the extent that we can really do effective jobs of providing necessary care in the home setting, I think it's clear to everybody that is socially preferred, it is medically preferred, and it's probably economically preferred, but that's the least of the motives there. And I think the third area that, and I was touching on this at the conclusion there, was in the expansion of telehealth. There's, particularly in the behavioral health side, been some enormous uptake and reported from both providers and consumer directions, really improved access and great acceptance. So that's an area that we will need to work very closely with the provider systems, but a lot of other stakeholders as well, to ensure that it never takes the place of consumer choice, but that we can find good ways of embedding it in the delivery system.
So for our folks watching, our attendees, I want to just let you know that this session is like all of our other sessions. They're all live, which is a little crazy making in the virtual space, but that means you can ask your questions right now. You can put them in the chat box and I'll see those and integrate those into the conversation. So I know you're not a shy bunch usually, so don't be shy here about posing your questions. We'll make sure that we try to get those integrated. Director, let me ask a clarifying question about the ability of MCOs to contract with community-based organizations and sort of, as you called it, I think the social care institutions. Would those contracts be part of the MLR, or would they be part of the administrative percentage?
I'm sure that they would be considered part of the MLR. Yeah. In that, I mean, the intention here is to have them as part of the delivery system, and the whole notion of in lieu of services is a service that is justifiable because it will accomplish the medical goal.
And I think that's a great ambition. It's a real game changer. We've heard people talk about the social determinants for a long time, as long as they're funded out of non-MLR funds, but moving them more directly into MLR is a big difference. On telehealth, how does the agency think about this question about parity for in-person of telehealth services being reimbursed at an equal rate to in-person services? Some folks argue that that telehealth is much cheaper and therefore pricing should be lower. Others say it's the parity that has catalyzed this entire transition that we have seen, and to remove that policy would be to undermine the success of telehealth. How do you sort of navigate that question of parity in terms of reimbursement?
with great care. I don't want to get out ahead of my skis on this, as a famous comment Obama said of Mr. Biden. But clearly, even prior to the pandemic, before the public health emergency, there was payment parity for some services in Medi-Cal. That was particularly in the fee-for-service side. In the managed care side, we've expanded that during the pandemic. Now I think it's time to sort of look at those services in terms of, is there a actual reduced cost for providing the care, in which case at some point that should potentially be reflected. And then distinguish between different types of telehealth. Synchronous visual telehealth versus asynchronous telehealth versus telephonic. All of these, I think, have to be considered in separate categories and for separate purposes, separate clinical situations and separate disciplines. So I expect what you will see is that after the turn of the year, we'll probably be sort of coming forward with some concepts to share with stakeholders in the legislature, and sort of really sort of try to work through a systematic approach to what is fair, yet preserves the energy that's gone into this over these past months. And then, of course, we have to be sure that whatever we're doing are things that are both CMS approvable in terms of things like HIPAA requirements, et cetera, but also reimbursable according to CMS standards. And as I mentioned, as we know, we're going to see a changed leadership there, and there may be sort of a period in which, as people take their roles, we may have to be patient in being able to sort of be clear where we land.
Let me ask this sort of personal question, which is, CalAIM is pretty innovative, I think. It was not clear where CalAIM was going to go at the beginning of this, but it's clear that it is the wind in the sails behind DHCS's vision for health reform in California, particularly Medi-Cal. And it is ambitious, both for California and comparatively to other states. It happens within the context, of course, of Governor Newsom having won a primary when universal coverage was on the ballot in some ways, and some stakeholders like the Nurses Association and others had strong opinions about the topic. And for better or worse, many in the Democratic Party looked to California. They looked to now Vice President-elect Kamala Harris, now apparently soon to be appointed HHS Secretary, Attorney General Becerra, and they looked to Governor Newsom for leadership on health reform. How does it feel to be one of his top healthcare lieutenants and having the country look to California for health reform? It sometimes feels like there's a gap between what is happening on the ground that is truly innovative and what is sort of expected by our political conversation. How do you kind of, work within the context of ambitious national politics and innovative on the ground reform?
I guess it's the old statement, don't let good and better become competitors. I think we share the aspirational goals the governor has stated frequently of sort of universal coverage is our goal. Whether or not that can be accomplished in a single payer type of construct, or it is really a weaving together of different public and private systems and programs, is something which I think we're going to spend a lot of time over the next couple of years exploring. As you know, the governor created a sort of commission on Healthy California for All to look at exactly the question of how do we get to universal coverage. The commission has been sort of paused for a moment because just the intensity of the work of the last 3 or 4 months the pandemic, but it will be re-engaging starting in January, I believe, and to really look at what are the possibilities. Clearly, we are dealing with a different federal environment than it would have been otherwise. One suspects there will be greater willingness to talk about ways in which Medicare and Medicaid can interact with other systems, whether that gets all the way to a single payer or it's a public option or what, I think we have to both continue to innovate on the ground with the programs we have, and at the same time preserve the room to take advantage of initiatives or breakthroughs that occur at the federal level. Obviously, there are still a couple of elections to be had before we know the full dimension of what's possible. So I think part of the challenge here is staying focused on goals and open to opportunities.
I want to get to some of our audience questions, but first I want to bring in the medical director for plan performance at Anthem and welcome you to our conversation here, Demetria Malloy. Thanks for making time. I appreciate it.
Thank you so much for having me. So nice to be here.
Yeah. So let me ask you, working at this sort of intersection of our traditional Medi-Cal model, but trying to meet the vision of innovation from DHCS, what stands out to you from Director Lightbourne's comments that you heard when he was speaking?
I mean, I think I've been ruminating on some of the things that Director Lightbourne just had to share. There's a lot of great elements there to unpack. And as I'm listening to him and thinking through, Anthem Strategy, our approach, where we've put in some substantive staff and time and strategy. It's really nice to know that we've, aligned a lot with where DHCS is going and are in a lot of agreement with that. In particular, an area that I've been working on a lot and a lot of the, cross-functionally across Anthem, the health equity piece for sure, as an underlying platform. And I often refer to it as a lens that we look at everything through. Our existing programs, how we construct programs that we are trying to put together and enhance as well, from everywhere to our contracting and network, to our case management, to our quality team, et cetera. And we've put together actually a governance body for the Health Equity Council that I co-chair with a director in quality to make sure that we have that representation when we have that formal discourse built in order to make sure that we are really applying that to everything that we do. I think, I wear a lot of hats a bit at Anthem and trying to drive some clinical performance across the board, but health equity stands out as a constant conversation that we integrate into all of those areas. And I think that a lot of it has begun with our work there and development has really begun with a lot of our approach. And I think, it can seem like a big, broad area that is not well-defined somewhat. And if there's a question of where do you start as any given organization, I think we've given a lot of thought to how does a payer and how do all of our potential partners work in this work to actually move it forward. And I did include a couple of slides there, and they really are just visuals a bit to anchor down a little bit more what some people feel can be a fuzzy area or less well-defined area. And I would argue, that there are definite niches and ways that you can define and then organize a team around achieving goals underneath that. So I think a number of the programs that Director Lightbourne noted that really always have that touchstone of health equity. Anthem has certainly tried to align with those and build in structures to make sure that we achieve that in our programmatic efforts.
How do you, Director Lightbourne mentioned that that the department wants to do more and a better job at holding MCOs accountable for the vision and performance in Medi-Cal. You're at that intersection. You've been working on plan performance for a good number of years now. What is different about how MCOs are performing vis-a-vis DHCS's vision today than maybe 4 or 5 years ago?
Some key areas, I would say partnership and innovation. I mean, I think I'm really excited to continue to hear the push for integrating different areas of the care system and, more formally supporting that to make sure that really is in service of the member and treats the whole person. I think when you look at the health equity lens as well, to do that, it's a little bit about making sure that the standard for all is raised, and so you raise all boats. But I think there's a lot of adaptation and customization that needs to happen so that you fill in particular gaps that the standard ways of doing things have not always filled in. And I think you have to look at data. I think that drives you to where those gaps are, because you're not always going to see them. If you sort of take a high level look at things might seem like they're doing well. But if you dig into the data a little bit more, it really helps you note which parts of, for us, the members that we serve are not doing as well. And then to target and try to say, where's the partnership? Where's the innovation there that would fill that gap in a, perhaps non-standard way. I mean, we're all executing on core standards that have been around for a while, and yet and still these gaps exist. So the question is, where in the community are there experts there that have other ideas or have other things that need to be empowered in a different way in order to fill that gap? So for example, for us, we looked, and our breast cancer screening in Fresno was at a good level. But if we dug into the data a little bit more, we found that the Hmong population was not doing well in that way. So the issue was, how do we partner with some of the leaders in the Hmong population in Fresno to have something more innovative to come out, information that we didn't know, ways to partner, et cetera. We did something similar with Southeast Asians and particularly immigrant populations in San Francisco in immunization rates. Overall immunization rates okay, but not with that particular population. And I would profile one last thing that I think in particular, I think everyone's noticed is well known to everyone, the maternal birth equity disparities, particularly with African-American women and also Pacific Islander and Native American women, and the birth outcomes that are much different between that and the Caucasian population. We built, a doula program for Anthem. I'll have to give it a special plug because we won the DHCS Health Equity Award this year for that particular program. But that was really in partnership a lot with local community-based organizations, letting us know what works, what works for a doula, what kinds of people. We had direct references from Black Infant Health, March of Dimes, et cetera, people that they've worked with to build a program. And I think our role was really to try and figure out how we could facilitate something sustainable. And we, worked to build a whole new contract, et cetera, to actually even have that organization be able to partner with us and provide those services, and have really made impact with that program and looking to expand it. So you have to look sort of outside of the box and find ways to use your position to help those things move forward.
Yeah, great stuff. Director Lightbourne, let me ask this question from one of our audience members who asked about if you would speak a little bit about the 1915B waiver and how that tool will be used for integration of physical and mental health care, and maybe just explain why we have had an 1115 waiver, the difference between a 1915B waiver and 1115 waiver, and for folks who are not purveyors of the Social Security Act, what is what?
Well, just before I respond to that, I do just want to really commend Anthem for the doula program in San Francisco. It's exactly what we're talking about, and as Demetria said, it's partnership, and I think we have taken on ourselves a responsibility to say it can't just be one example like that. What can we do to carry forward Anthem's example there? To touch briefly on the 1915B distinction. What the 1115, well, later on today, you're going to have J.C. Cooper on, and J.C. knows more about federal waivers than anybody. But the short version is the 1115 waiver was necessary because it allowed us to waive statewide requirements. And so we could have whole person care in some counties, not others. We could have health homes in different places. We could have the drug medical organized delivery system in some places, not others. With going to the 1915 B waiver, we're essentially giving up that sort of regionalization of care and moving much more to over time, a statewide footprint where we will say, wherever in California you are, these are services that should be available, must be available to you as a Medi-Cal beneficiary. So it's a sort of it's stepping out of the pilots, if you will, into real time.